Welcome to a deep dive into the body, focusing on arrhythmia, the electrical heart. We will understand how the heart generates electricity and what happens when this crucial system fails. Right now, your heart is beating, lub-dub, lub-dub, lub-dub. It is perfectly rhythmic and timed, like the most precise musical instrument ever created. But what if that perfect rhythm suddenly broke? What if your heart started beating irregularly, chaotically, and unpredictably? This is arrhythmia, a disruption in the heart's electrical system. Depending on the specific type, the consequences can vary drastically, ranging from completely harmless to instantly fatal. Welcome back to the most electric deep dive yet. Today is all about the electrical system of the heart. Our deep dive map will cover generation, how the heart creates its perfect beat, malfunction, what happens when it goes wrong, interpretation, reading an ECG, and management, how nurses monitor and manage these conditions. Keep your pen ready. This is one of the most visual topics in all of physiology. We are going to draw a lot today. Let's dive in. Welcome to part 1 of this video on arrhythmias, focusing on the electrical conduction system. We will explore the anatomical pathway that creates the perfect heartbeat. Contrary to what many believe, the heart does not require a signal from the brain to beat. It generates its own electricity, a property known as autorhythmicity. Station 1 is the sinoatrial, or SA, node, the heart's natural pacemaker. Located in the upper right atrium, it spontaneously initiates an electrical impulse 60 to 100 times per minute. This ripple effect causes atrial contraction and corresponds to the P wave on an ECG. Station 2 is the atrioventricular, or AV node, which acts as a gatekeeper controlling the impulses. It causes a critical delay of about 0.1 seconds to allow the atria to finish contracting and empty blood into the ventricles before the ventricular contraction begins. This delay correlates with the PR interval on an ECG. The impulse then moves into the ventricles. First, Station 3, the bundle of His, sends the impulse down the interventricular septum. Next, Station 4, the bundle branches, splits the signal to both sides. Finally, Station 5, the Purkinje fibers, a vast network, rapidly spreads the impulse, triggering a powerful, simultaneous ventricular contraction. This is the QRS complex on the ECG. In summary, the SA node initiates the impulse, causing the atria to contract. The AV node delays the signal for ventricular filling. The bundle system carries the signal down the septum. Finally, the Purkinje fibers cause the ventricles to contract simultaneously. The heart has built-in fail-safes. Each station has an intrinsic firing rate. The SA node is the primary pacemaker. If it fails, the AV node acts as a secondary backup. If both fail, the Purkinje fibers, though very slow, provide a last resort backup to keep the heart beating. The body has engineered remarkable redundancy. This sophisticated electrical system provides built-in backups for the heart, its most vital organ. It never gives up without a fight. Welcome to part 2, Reading the Heart. In this video, we will focus on translating the heart's electrical activity into visual data. The electrocardiogram, or ECG, is how we can visually see the heart's electrical activity on paper. It is the single most important diagnostic tool for any arrhythmia. A normal ECG shows a regular repeating pattern called the PQRST complex. Each letter represents a distinct electrical event in the heart. When functioning properly, it is regular, consistent, and beautiful. The P wave represents atrial depolarization, the electrical activation that causes the atria to contract. The PR interval is the time it takes for the impulse to travel from the SA node through the AV node to the ventricles. If the PR interval is longer than 0.20 seconds, it may indicate a heart block. The QRS complex signifies ventricular depolarization, causing the ventricles to forcefully contract. If wider than normal, it may suggest a bundle branch block or a ventricular arrhythmia. The ST segment is the flat line after the QRS, where the ventricles are fully depolarized. Elevated or depressed ST segments are extremely important in nursing, as they can indicate a heart attack or ischemia. The T wave represents ventricular repolarization, the heart's electrical recovery. Peaked T waves can indicate hyperkalemia, while flat or inverted T waves may suggest ischemia or electrolyte issues. The QT interval is the total time for ventricular depolarization and repolarization. A prolonged QT is dangerous, potentially leading to torsades de pointe. Here is a quick summary of the normal ECG waves and intervals, their electrical events, and the resulting mechanical action of the heart. We have seen the pattern for a healthy heart. Regular, consistent, beautiful. Now, let's explore what happens when this pattern goes wrong. Welcome to part 3 of the arrhythmia video, where we will discuss what arrhythmias are and the underlying mechanisms that cause them. Arrhythmia is an abnormality in the rate, rhythm, or conduction of the heart's electrical system. This means 3 primary things: tachycardia, a heart rate above 100 BPM, bradycardia, a heart rate below 60 BPM, or irregularity, which is chaotic or abnormal electrical signaling. So why does arrhythmia happen? There are 3 main electrical mechanisms that cause arrhythmias. Mechanism 1 is abnormal automaticity. This occurs when cells, other than the SA node, start firing electrical impulses on their own. These ectopic foci fire at the wrong times, interrupting the normal rhythm and creating extra beats, like premature atrial or ventricular contractions. Mechanism 2 is re-entry. This is the most common cause of serious, life-threatening arrhythmias. Instead of the electrical impulse dying out normally, it finds a circular pathway and continuously excites the heart, like a dog chasing its tail. This causes rapid, sustained arrhythmias, such as atrial and ventricular fibrillation. Mechanism 3 is conduction block. This occurs when the electrical pathway is damaged, diseased, or severed, causing the impulse to be severely delayed or completely stopped. This results in heart blocks, where the ventricles may rely on slower, backup pacemakers. Many factors can cause arrhythmias, including coronary artery disease, heart attack, hypertension, electrolyte imbalances, and certain medications. Thyroid disorders, toxins, hypoxia, structural heart disease, and congenital abnormalities can also trigger arrhythmias. Welcome to part 4 of our video on cardiac arrhythmias, where we will discuss ECG patterns, underlying mechanisms, and essential clinical management strategies. We will explore the full spectrum of arrhythmias, ranging from relatively benign physiological responses to severe, life-threatening medical emergencies. We'll systematically review the primary types from least to most dangerous. First, sinus node abnormalities include bradycardia, where the heart rate is below 60 BPM, and tachycardia, where the rate is above 100 BPM. Treatment involves managing symptoms or addressing the underlying cause. Atrial flutter involves the atria firing rapidly at 250 to 350 BPM, creating a distinct sawtooth pattern on the ECG. Treatment focuses on rate control, rhythm control, and continuous anticoagulation. Atrial fibrillation, or AFib, is the most common serious arrhythmia. Hundreds of chaotic electrical impulses fire from the atria, causing them to quiver. The ECG shows no clear P waves and an irregular ventricular rhythm. The dual dangers of AFib are the loss of, quote, atrial kick, leading to reduced cardiac output, and the formation of blood clots due to stagnant blood. This makes anticoagulants mandatory to prevent strokes. Atrioventricular heart blocks are classified by degree. First degree is usually benign with a prolonged PR interval. Second degree blocks involve dropped QRS complexes. Third degree is a complete heart block requiring an immediate pacemaker. Ventricular tachycardia, or VT, occurs when an ectopic focus in the ventricles fires rapidly. This results in wide, bizarre QRS complexes and a dramatic drop in cardiac output. Treatment ranges from amiodarone to immediate defibrillation. Ventricular fibrillation, or VF, is the most deadly arrhythmia. The ventricles quiver chaotically, generating zero cardiac output, which results in cardiac arrest. The ECG shows a chaotic, irregular baseline with no recognizable waves. Brain cells begin dying within 4 to 6 minutes of ventricular fibrillation due to a lack of oxygen. The only effective treatment is immediate defibrillation to reset all cardiac cells, combined with uninterrupted CPR. This summary table highlights the key ECG features, primary dangers, and first-line treatments for the most critical arrhythmias, helping to distinguish between life-threatening emergencies and less severe conditions. Welcome to Part 5, Symptoms and Diagnosis. In this video, we will explore how patients present with arrhythmias and the key diagnostic tools used to identify and characterize these irregular heart rhythms. We begin by discussing the clinical presentation, covering how patients experience irregular heart rhythms and the physiological mechanisms behind the common symptoms. Palpitations are the most common symptom, described as a fluttering, pounding, or racing sensation. Dizziness and lightheadedness result from reduced cardiac output, where less oxygen-rich blood reaches the brain. Syncope, or fainting, is a sudden loss of consciousness due to an abrupt reduction in blood flow to the brain. In life-threatening arrhythmias like ventricular fibrillation, syncope is a critical sign that the heart is failing. Breathlessness occurs as the body struggles for oxygen due to reduced cardiac output. Chest discomfort, or ischemic chest pain, can be caused by fast heart rhythms increasing the heart's oxygen demand, especially in patients with coronary artery disease. Sudden cardiac death is the most severe outcome. In ventricular fibrillation, the heart stops pumping blood entirely. Immediate defibrillation is crucial, as irreversible brain damage and death will occur within minutes without treatment. Next, let's explore the diagnostic modalities, the essential tools used to identify, monitor, and characterize cardiac arrhythmias to guide accurate treatment. The 12-lead ECG is the gold standard for arrhythmia diagnosis. It records the heart's electrical activity from 12 angles, offering a comprehensive view of electrical conduction that allows trained professionals to identify most arrhythmias immediately. A Holter monitor is a small, portable ECG device worn continuously for 24 to 48 hours. It's essential for capturing intermittent arrhythmias that may not be present during a brief standard ECG in the clinic, recording every single heartbeat. The electrophysiology study is an advanced internal diagnostic. A catheter is inserted into the heart to directly measure electrical signals. This procedure can deliberately trigger an arrhythmia to map its origin, which is often a precursor to curative ablation therapy. An echocardiogram assesses the heart structure and pumping efficiency, identifying structural causes of arrhythmias. Laboratory blood tests are crucial for systemic causes, checking electrolytes, thyroid function, biomarkers like troponin, and drug levels.